நான் இந்த பாலமுருகன் சார்ட்ட சொல்லியிருக்கேன், பேசிடுறேன்.
Good evening, Ramesh. Welcome.
மியூட் ரமேஷ் சார், அன்மியூட் பண்ணுங்க.
Unmute பண்ணுங்க.
மியூட் பாருங்க.
எல்லாம் கேபிட்டல் லெட்டர்ல போடணும் அந்த பாஸ்வேர்ட்.
Now it's audible, sir.
Audible. நல்லா audible.
Faculty, we are connected on YouTube. Ramesh sir, welcome. Paul sir, welcome, sir.
Thank you, sir. Good evening, all of you.
Good evening, sir.
I must thank the Chennai branch and Marudhuvandian, sir.
Thank you, sir.
Talking this.
Chandru, Sagayam மட்டும் ஒரு அடிங்க Chandru.
அடிச்சறேன் சார்.
பாலமுருகனுக்கு சகாயம் மட்டும் அடிங்க.
அடிச்சிட்டேன் சார். இந்த மெசேஜ் போடுறேன்.
அலெக்ஸ் என்னாச்சு
சார்? அலெக்ஸ் வந்து அவர் வில்லேஜ்ல இருக்காராமாங்க சார். அவர் வந்து ஒரு 5 to 10 மினிட்ஸ்ல ஜாயின் பண்றாராம். அவர் ஜியோ செட் பண்ணிட்டு ஜாயின் பண்றேன்னு சொல்லிருக்காங்க சார்.
ஓகே.
வெல்கம் டாக்டர் ரமேஷ் சார்.
Chandru.
வெல்கம் டு சென்னை சிட்டி பிரான்ச்.
Thank you.
இருங்க பேசிட்டு வரேன்.
சந்துரு நீங்க ஒரு கால் அடிச்சிருங்க சந்துரு எல்லாருக்கும். விவேக் சார், குட் ஈவினிங் சார்.
Sir.
குட் ஈவினிங்.
சொல்லுங்க கனவேல்.
சார், ரமேஷ் சார், குட் ஈவினிங் சார். வெல்கம் சார். Thank you for joining us.
Good evening, all of you. Thank you for the opportunity. I must thank the ASI and Marudhuvandian, sir.
Yes, sir.
ASI Chennai.
Thank you, sir.
Sir, சொல்லுங்க சார்.
Hi, sir.
சரி சார்.
Sir,
good evening, sir.
Vivek.
Good evening, sir.
சார் சொல்லுங்க சார்.
சார் நான் ஒரு மீட்டிங்ல இருக்கேன் சார், நான் திருப்பி பேசுறேன்.
Dr. Kanagovel, just checking you can hear me well.
Sir, Veganandan sir.
Nalla kekudha.
Good evening, Ramesh.
Good evening,
Very
sir.
clear, sir. Paul, sir, it is very clear.
Okay, thank you.
Thank you for coming, sir.
I could see Dr. Paul also, J. Paul, sir. Sir, do you remember me? You had a chance. CMC Vellore, I came there for one similar panel discussion on thyroid cancer.
Yes, thank you. Vanakkam Ramesh, how are you?
Fine, sir. Fine.
Good to see you.
Balaji, on video.
ஹலோ சரி சார், நான் பார்த்துக்கிறேன் சார், நான் ஃபாலோ பண்ணுறேன். கண்டிப்பாக பண்ணுறேன் சார், கண்டிப்பாக சார். நான் இது மீட்டிங்கில் ஒன்று இருக்கேன், எப்படி நான் முடிச்சுட்டு வந்துடுறேன். இல்லை வந்துடுறேன் சார், நோ ப்ராப்ளம். தேங்க்யூ சார்.
விவேக் சார், we are at 8 o'clock. Can we start, sir? Others can join.
Yeah.
Thank you,
Sir, in this meeting, how many postgraduates are logged into this meeting, sir?
Sir,
any idea?
இந்த இது வந்து we will know in the YouTube, sir. This Zoom is only for faculty and EC members of ASI, sir.
Okay.
So this will be having only maximum 20 or 25 people as everybody come in. நான் ப்ரோக்ராம் முடியும் போது உங்களுக்கு அப்டேட் பண்றேன் சார். யூடியூப்ல எவ்வளவு பேர் இருக்காங்க அது என்னால பார்க்க முடியும் சார்.
Okay.
So Chandru, Uttakumar sir.
Yes, sir.
Can we start, sir?
Okay.
Uttakumar sir.
Okay.
Yes, sir. Marudhu sir, can we start, sir?
Yes, sir, please, sir, we'll start, sir.
Chandru இல்ல அவரு சகாயத்துக்கு ஃபோன் பண்ணிட்டு இருக்காருன்னு நினைக்கிறேன்.
Wait for 2 minutes.
Balaji sir, we can start link, sir.
Please, sir, we can start, sir.
Yes, sir. கண்ணன் சார் இப்பதான் வராரு உள்ள, ஒரே ஒரு செகண்ட். கண்ணன் சார், குட் ஈவினிங் சார். சார், குட் ஈவினிங் சார்.
Good evening, Kanak.
Thank you, sir. Thank you for joining, sir. Andrew? Okay. With the permission of all the faculty, I'm muting all of you. Those who are going to speak can unmute yourself. We call the good evening, friends, both in Chennai and across the state. We have a few of the national delegates also watching on the YouTube. I would request faculty who are on the YouTube can join us in the Zoom. I warmly thank my co-leaders of Chennai City branch. Specifically, we have the luxury of having one of the General Council member, Dr. Chandrasekhar sir. And in fact, the convener for the day today is also a General Council member, Professor Marudhupandian sir. We are happy to welcome the General Council members of the National ASI for this evening's program. I warmly welcome my immediate past chairman, Vivekananda Subramanianathan sir, as well as the Director of Surgical Studies for guiding us through the academics and joining us for today's program. I thank my senior colleague, friend, mentor, Professor G. Uttarakumar sir, Professor of Surgery, ACS Medical College, for joining today. He is also the Honorary Secretary of the Chennai City branch. I warmly thank my friend, guide, and Professor Dr. R. Kannan sir, the treasurer of the Chennai City branch, and he's the CEO of the Prime Indian Group of Hospitals. Thank you, sir, for joining us. And I warmly welcome all the EC members of Chennai City branch, Dr. I sir, Dr. A.K. Rajendran sir, all other Pandi Raja and other delegates. We also welcome the invited faculty for the day. Once again, I thank Marudhupandian sir for shortly agreeing to do this panel discussion amidst this busy schedule. He was kind enough to immediately agree over phone that he will be able to do the program. And I also thank the panelists for the evening by the alphabetical order. We have Balamurugan sir from Stanley Medical College. He is the Professor of Surgery in the Department of Surgery. And we have Professor Balaji Singh sir, the Dean of Students and Professor of, Head of the Department of General Surgery, Sri Ramchandra Institute of Higher Education and Research. We welcome Balaji sir. Thank you sir for joining us. We have next the dynamic team from all over the state. We have Dr. Professor M. Ramesh sir. He is the professor and HOD of Surgical Oncology, Madurai Medical College. We have Professor R. Kannan sir. Again, he is the director, professor and head of the Department of Institute of General Surgery, Madras Medical College. Again, our well-wisher and who also kindly accepted over a phone call. Thank you, sir, for joining us. And the most important guest for the day, Professor M.J. Paul, is the head of the Department of Endocrine Surgery, Christian Medical College Hospital, President-elect of the Indian Association of Endocrine Surgeons. We are happy to have you on board, sir. Professor Paul M.J. is a very avid, good researcher in surgical endocrinology. And he also is a proponent of minimally invasive thyroidectomies. We will shortly have a combined program with the IAS also. So then we have our EC members, Dr. Sagai Inbasegar sir and Uttarakumar sir, whom I've already introduced to you, will be the co-panelists. Today, we are happy to have the very important panel discussion of experts in thyroid. We are going to discuss about the various management issues of well-differentiated thyroid cancer. Dr. Marudhupandian sir will be highlighting upon what is the right way to stage, what are the newer markers, whether there is limited thyroidectomy or conservative thyroidectomy is possible, the importance of adjuvant and neoadjuvant therapy, how to manage thyroid disease when it is gone beyond the confine of thyroid. And he is also going to address us on what is changing in the management in the year 2020. So thank you, Marudhu sir, for accepting to join us today. And I, in fact, warmly welcome all the senior faculty in the YouTube and the delegates of entire state and across the state, out of the state, who are watching us in YouTube. Thank you, dear friends, for joining us today. We would request all of you to give your questions in the YouTube chat box. We will first have the questions amongst the panelists, and then we will have the questions from the YouTube box also. I will request Marudu sir to address to those questions once we get the questions there. It can be, if it is associated to the question what sir is planned, then we will not be asking that question, because Marudu sir has a long list of management questions covering various issues. If that question is not covered by the panelist or something, then we will have that question, or we will have important questions at the end of the panel discussion. So this will be the flow of the program. Now, I request Dr. G. Chandrasekhar to formally introduce the convener, Professor Marudu Pandiyan sir. Chandru. Dr. Chandrasekhar. Chandru. Chandru, warmly, can you please introduce our convener for the evening, Professor Marudu Pandiyan sir?
Hello.
Chandru.
Yes, sir. Yes, sir. Clear.
Please introduce Marudu Pandiyan sir.
Welcome, welcome. The Chennai City branch welcomes. Very proud to welcome our Professor Dr. D. Marudu Pandiyan sir, former Dean of Madurai Medical College, and also the Executive Committee member of National ASI, and he is the known teacher to all, including the postgraduate, undergraduate, and all the well-practicing local surgeons of Tamil Nadu. So we welcome Professor Dr. D. Marudu Pandiyan sir for this panel discussion from our Chennai City branch. Welcome, sir.
Thank you, Chandru. Marudu sir, can we start the panel discussion?
Yeah, we'll start, sir.
Sagayam sir is yet to join, and Alex sir is yet to join, sir. All other panelists are here in the forum.
Okay.
So I will, with your permission, I will share the PowerPoint now, sir. Then you please advise me how to proceed. Then I will be able to help you out.
I will be able to see the yeah.
Are you able to see the slides, Marudu sir?
But I can't see the list of faculties.
Sir, this is the first slide I made as a filler slide, sir. Then we will have one by one, sir. As you say advance, I will advance, sir. Can I go to the next slide,
I can't see the whole panelists.
Sir, you can make the view into the multiple view, sir. Then you can see the list of the people also, sir.
Okay.
On the sides, there will be speaker view, sir. On the right top, you have a button, sir. Then you will be able to see all the speakers under you, sir. When you see the PowerPoint, on the right top, you have a speakers view, sir. There will be multiple checkered box, sir. I am sending right now how I am able to watch, sir. You can also use the same method, sir. Are you able to do that, sir? உங்களுக்கு ஸ்லைட் தெரியுதுங்களா மருது சார்?
For 1 minute, sir.
Yes, sir. Yes, sir.
Share screen போடு.
சார் இப்போ நீங்க ஸ்லைடு காமிக்க போறீங்களா சார்?
இல்ல நீங்க தான். Next I will tell next. I want to see the entire list of panelists in view.
சார் நீங்க ஒரு வேலை பண்ணுங்க சார். நீங்க இன்னொரு டிவைஸ்ல இதே இது லாகின் பண்ணிக்கோங்க சார். இன்னொரு டிவைஸ்ல லாகின் பண்ணிக்கோங்க சார். இப்போ இதுல இருக்குறதுல உங்க போன்லயாவது ஏதாவது லாகின் பண்ணிக்கோங்க.
Got it, sir. No problem.
Okay, sir. Can we advance the slide, sir?
1 minute, sir.
Yes, sir.
Good evening, all of you. First of all, I congratulate the new team of office bearers for Chennai City branch. Dr. Kanagavelu as chairman, Dr. Uttarakumar as secretary, Dr. Kannan as treasurer, Dr. Chandru as vice chairman, Dr. Vivek as director of surgical studies, and all other EC members, Dr. Pathiraja, Dr. Izar, and my good friend Dr. Balaji Singh, Dr. Kannan, Dr. Ramesh, HOD of Surgical Oncology Madurai, and Dr. MJ Paul from Vellore. Really, it is a happy moment for me to share some of my thoughts in well-differentiated thyroid cancer management. Hope it will be useful for the exam-going PGs. I'll give a clinical scenario of a case and I'll put forth some questions to the panelists. And at the end, if you want, I can make a summary of our presentation. With this, I request Dr. Kanagavel to move on to the next slide. Coming to this clinical scenario, a 25-year-old lady who has got a neck swelling for the past 9 months, which is progressively increasing in size. She has got no pressure symptoms. On examination, there was a small nodule, solitary nodule on the right lobe of thyroid, and there are multiple lymph nodes palpable on both sides of the neck. So my first question goes to my good friend Dr. Balaji Singh. How will he clinically suspect that the given nodule in the thyroid is malignant or not?
Obviously, sir, when there are multiple lymph nodes and duration is 9 months, as everyone know, there is no age criteria. Younger patients do get differentiated thyroid malignancy, of which nearly 65 to 70% are PAPCAs. So obviously, with the lymph node positive, we have to think in terms of malignancy. One is the duration, being a lady, solitary nodule, lymph node palpable, you said, bilateral cervical. Obviously, a diagnosis has to be, first thing in mind is malignancy only. The two PAPCA we have to think because of the age. Obviously, sir, like like any other malignancy, it may not be hard, and we are all feeling it through the stap muscles and the neck. So obviously, it may be firm. If it is hard, definitely we have to think in terms of it, and we have to see the nodes, what are the size of the nodes and everything. And classical examination need to be done, though there are no pressure symptoms. You have to check all the level of nodes. And the classical way how we are inspecting, examining, all those things has to be done, sir. And definitely, you have to think in terms of malignancy only in this case because there is lymphadenopathy. There is no doubt or no ambiguity in it.
Thank you, sir. As sir rightly told, if the nodule is having short duration and that too family history, on clinical examination, you may find a nodule in the thyroid. It may be cystic or solid. The intrinsic mobility may be fixed. You may have the loss of carotid pulsation sometimes, and multiple nodes, as sir rightly told. In this case, patient has got bilateral neck nodes. So in this scenario, we have to think it as a malignant thyroid lesion. The next question, next slide.
So one more option, sorry for postgraduate sake, sir. Bilateral neck nodes and a nodule in the thyroid, they should also think in terms of lymphoma also. So they should have it in mind. Younger patient can be a lymphoma, though B-cell lymphomas have been reported in thyroid. Okay, we have to think that as a secondary diagnosis because you said multiple bilateral. Yes. So with that thing, you should have also, I should have in mind about lymphoma as well. I'm sure Dr. Ramesh will agree with that, though the incidence is low, because specifically you mentioned bilateral. And the characteristics of the node has to be assessed.
Yes, sir.
As sir rightly pointed out, there is in the presence of bilateral lymphadenopathy, any thyroid nodule, first we have to think in terms of malignancy. You have to do all the subsequent imaging and the FNACs to either prove or disprove. But unless proved otherwise, we have to take it in terms of malignancy only. And the second thing he raised about the possibility of lymphoma. In the scenario of bilateral cervical lymphadenopathy with the thyroid swelling, the primary lymphoma thyroid is extremely a rare possibility. Rather, I will think in terms of a primary lymphoma with the incidental thyroid nodule. That could be another possibility. That can be clinched only by the excision biopsy of the cervical lymph node. a thyroid lymphoma with metastasis or with simultaneous presentation of the lymphadenopathy is quite uncommon to think in terms of both thyroid and the lymph node together as a single entity. Rather, I will think it is a lymph node could be in a 25-year-old female. The bilateral lymph node could be a primary lymphoma, and thyroid may be an incidental benign nodule. That is a much more common presentation than the primary lymphoma with lymph node presentations.
Yes, thank you, Ramesh. Next slide.
One second, sir. One second.
So the clinical suspicion of malignancy. This question goes to Dr. Kannan, MMC. So how will you proceed in this case? In other words, what is the line of investigation you want to do in this case, sir?
Yes, sir. This patient has presented with the thyroid swelling and as well as a lymph node enlargement also.
Yes, sir.
The first and foremost investigation we must do is the ultrasonogram of the thyroid.
Yes, sir.
It is very, very important. The workforce. An ultrasonogram of the thyroid can identify the number of there is a nodules in the thyroid, either the single or multiple, and the echogenesis, whether it's a solid or system. The TRACs, the thyroid imaging and the reporting data system, gives 5 points. The 5 points are: one is the echogenesis. Hypoechoic lesions carry a bad prognosis, so they are more malignant. They carry 2 points. The second is the capsular breach, that carries 1 point. The third one is taller than wider, that carries 1 point. And the fourth one is calcification. 5 microcalcification more in favor of thyroid malignancy. Whereas coarse calcification is a benign image. So the TRACs use the methodology to identify the thyroid nodule as well as the lymph node enlargement. In case the lymph nodes are enlarged, the lateral nodes and the central nodes. The central nodes are not that much picked up by the ultrasonogram, especially when they are below the mammography. Whereas the lateral nodes can be picked up. The number of nodes, then the size. When it becomes a little oval, rounded, then the hypoechogenicity. Then the Doppler that shows the increased vascularity, then the hilar vascularity, then the loss of hilar fat. All these things give an idea that it is a secondary to the thyroid lesion. Then the FNAC is dependent upon the findings in the ultrasound. So when it is graded into derived grades into various grades, so these grades says whether the FNAC is needed. If it is a malignant lesion in ultrasonogram, we can, even if it's less than 1 centimeter, we can go for an ultrasound guided FNAC. Other than that, 1.5 centimeters or 2 centimeters, we can in the ultrasound guided FNAC.
Kannan sir, just can take a line of investigation, sir, and I will put a separate question to each of the panelists. What are the findings?
Initially,
findings in FNAC?
You given me the ultrasonogram findings. That's why I told all these things. Line of investigation is first is the thyroid function test, ultrasonogram, FNAC.
Yes, sir. So having said ultrasound is of the thyroid is the main first investigation. What are the findings you will get it in ultrasound to say it is a malignancy? This question goes to Dr. Alex. Are you free now?
Madhu sir, we have a national faculty also joining us. We have Professor Deborshi Sharma from Vardhaman Mahavir Medical College. We have Professor Guru Shantappa sir from Hubli. We have Professor Hitesh Andaria sir from Ahmedabad. We have Dr. Rajiv Nandan Sahai sir from National Municipal Medical College, New Delhi, and many other faculty have joined us, sir.
Alex has come or not, sir?
Alex is joined, sir.
Joined.
We welcome all the national faculty to Chennai City branch. Welcome, sir. Okay, Martha sir, proceed.
Dr. Alex.
Sir, Alex sir, unmute பண்ணிக்கங்க, sir.
Okay. In that case,
sir, Alex sir is with us, sir. Give me a minute, sir. Give me a minute. Alex sir, unmute பண்ணிக்கங்க, sir.
Alex, unmute.
Manage.
Welcome,
Yeah.
Yes.
Alex. Now tell me the ultrasound findings of thyroid to say it is malignant. What are the ultrasound findings to say it is a malignant one?
Alex, unmute.
Unmute.
You take the button of mic.
We warmly welcome Professor Tejasvi from Bangalore. Dr. Sagai Indrasekhar sir has joined, sir.
Alex, shall I pass on this question to you?
Sir, we pass on to the next person.
Mic unmute.
Dr. Guru Santappa. He's online.
Dr.
No.
Guru Shantappa, Dr. Hitesh is there, Dr. Rajiv Sahai, Dr. Deborshi Sharma, Dr. Tejasvi is there, sir. Can anyone of you take the question, sir? Dr. Rajiv Sahai? I think we'll request Paul, Professor Paul to take up the question, sir, please.
Hello, yeah, you can hear me?
Yeah, very well, sir.
Yeah, I'll just a couple of comments. First, about the clinical evaluation, we use the term triple assessment for any nodule which is classically claimed from the breast. And in thyroid, since we add on the functional assessment with biochemical assay, we can actually call it a quadruple. There are 4 things: clinical, radiological, FNA, and functional biochemistry. So that's a good way of thinking of how we are looking at the nodule. Now, in terms of this particular case, just a small point, very important for our country, whenever you have small thyroid nodule with nodes, as we know, multiple lymphadenopathy can be tuberculosis or lymphoma, as was pointed out. TB always is in differential. We must remember that in any presentation, tuberculosis must be thought of. So when you have nodes out of proportion to the nodule, we must also think of medullary carcinoma thyroid. And sometimes they can be little tender, the nodes. Papillary cancer typically presents either a small hard nodule with multiple nodes, or can be a larger cystic area with multiple nodes. Now, coming to this assessment, we're talking about the ultrasound. It's good to know the history a little bit about the development. An ultrasound of the thyroid was done for a long time without a scoring system. And finally, it was this first group from Korea, Kwak-Ten group, actually in 2007, they came out with this scoring, which talked about the consistency, that's the echogenic feature, then the border, the presence of calcifications, the margin, and associated lymph nodes. Now, that was the early thyroid scoring, which was just 1, 2, 3, 4, 5. It was very simple. And as you know, the 4 was suspicious and 5 was highly suspicious of malignancy. Later on, they wanted to make it a little more specific. So they introduced a 4ABC. And then now we have what is called the ACR thyroids of the American College of Radiology, which gives a TR score to each of these findings. And depending on the score, they give the thyroid scoring 1 to 5. So currently, when you get a report, you must know that whether the radiologist has used the ACR thyroid scoring, which is supposed to be a little more sensitive and specific, or is using the Korean thyroid score. Sometimes that's called K thyroids. To add to the confusion, the Europeans also have added a EU thyroids. Now, if we look at this image, you can see clearly what are the findings in favor of a malignant nodule. And you can think of it as 5 components. First is the composition. That is it solid or cystic, or is it mixed solid cystic? An important term is spongiform. So you can see the first image on the top left has a cystic area with a small solid component. So it's a mixed solid cystic. The second one is fully solid. That is B. Now to the classification, when we say spongiform, I don't think there's no spongiform in this. The importance of spongiform is that it is almost certainly benign. So when you have multiple small cystic areas within heterogeneous nodule, it gives a sponge-like appearance, and that's usually classified as Thyroids 2 or very likely to be benign. Now mixed, the solid must be thought of as, is it echogenicity is same, less or more than the normal thyroid gland that's surrounding. So like in figure C, you can see clearly the normal thyroid with the solid nodule, and there's some calcifications as well within. So that is what we call almost isoechoic. That's around the same. Now, to be suspicious of malignancy, it should be hypoechoic. And in fact, in the ACR Thyroid's latest scoring, they have given markedly hypoechoic, even more suspicious of malignancy. That means it's close to cystic. Now, the important concept there is when you have very cellular lesions, they actually have a lot of water content in the cell, so they tend to pass the sound waves easily. So they become more and more hypoechoic as the cellularity increase. So more aggressive neoplasms are more cellular and therefore will appear more hypoechoic. Therefore, hypoechogenicity relative to the normal thyroid is a marker of malignancy. Then the border you can see in C, there's a hypoechogenic border all around. So that is also a marker, that is a margin of the thing. If it is smooth and well defined, as you can see, then it points to a benign lesion. If it is lobulated or irregular, then you call it suspicious. And if you actually have what looks like tumor coming out when it's near the capsule of the thyroid or extrathyroidal extension, then that is highly suspicious. The shape is also important. So we give now normally in glandular structures, when there is a lesion, a benign lesion tends to take the shape of the gland. The same thing you can see in the breast also. But if it becomes rounded or taller than wide, as tall and wide or taller than wide on the cross-sectional imaging of the ultrasound, then we say that is a pointer to a malignant nodule. The fifth point, is echogenic foci. That is, if you have earlier we used to call it microcalcification, but in the ACR Thyroid's categorization, it's now called echogenic foci. That means it uses microcalcification as well as inspissated colloid, which appears like calcification, are together bunched as echogenic foci because it's difficult sometimes to differentiate. Classic inspissated colloid will give what is called a comet tail artifact. I don't think there's an example in this picture, but if you have these shadows thrown behind these punctate echogenic foci, that is what we call comet tail. And that tells you that that is colloid and that is very benign. So that will not get any points. Now, macrocalcifications is more likely to be benign than microcalcifications. But what they found in the ACR thyroids, when you have macro and micro together, that is very suspicious. The last point in calcifications, you may get rim-like calcifications. Rim-like calcifications around the border. If it is a complete rim, it is benign. But if it is a broken ring or there is soft tissue extending beyond the ring, then that is suspicious. So these are all the pointers on ultrasound for malignant nodules.
Okay, sir. Thank you, sir. As summarized the ultrasound findings of a malignant nodule. And by the way, he has added a word on thyroid's classification based on ultrasound findings. Now, The next question to Dr. Uttarakumar. By doing an ultrasound, you can say the given lymph nodes in the neck, whether they are secondary deposits or not, by doing an ultrasound. So tell me the findings in ultrasound to say the palpable nodes in the neck are secondary deposits. This question to Dr. Uttarakumar.
Yes, sir. So really, especially the papillary carcinoma of the thyroid. Anything the lateral aberrant of thyroid, there is a thyroid follicles may be present. So especially these findings may be present, but occult primary or anything is a percentage of the lymph nodes. We cannot find out whether this is a thyroid primary or anything. The nodes secondaries in the neck. So maybe the 60% may be the squamous cell carcinoma, 20% may be adenocarcinoma. So nothing anything. So not special findings in the lymph nodes findings. Only the thyroid follicles findings may be present.
Professor Marathu sir, we have Professor Ajay Khanna from Banaras University, Varanasi. We have Professor Pankaj sir, again Pankaj Modi from BGM Medical College, HOD, Ahmedabad. We have the Professor Jailal sir also with us. Over to you.
Dr. Guru Santappa, can you add anything on this ultrasound findings of an lymph node to say it is secondary deposit? He's online.
Yeah. I am online. Is it audible?
Very well.
Yes, sir. Yes, sir.
Okay. Yeah. Other than points, what has been mentioned, the loss of like any other lymph node deposits. Whenever we talk about deposits in the lymph node, loss of the hilum of the lymph node, one. And second, sometimes we will be able to see even microcalcification like what is seen in the primary. Sometimes it is also seen in the deposits also. Not necessarily in all the cases. So addition of these 2 points may add to the diagnosis.
Yeah, and can I just add cystic change and peripheral vascularity? So in ultrasound for lymph nodes, you divide in two categories, morphology and size. Morphology, as was said, is loss of fatty hilum, cystic change, microcalcifications, and peripheral vascularity around the node. These are the 4 features that tell you it's likely to be malignant. The second is the size criteria, which is not as specific as morphology criteria. And we say that anything that reaches 9 millimeters in short axis dimension can be significant. That is without loss of fatty hilum or any morphological change.
Sir, Marathu sir, you are in mute mode, sir. Please unmute yourself.
So as we discussed the role of ultrasound in thyroid, we will move on to the next investigation, FNAC in thyroid. So this question to Dr. Sahai
Sir.
Is joined?
Sir, he is with us, sir.
So he's joined, sir, but his audio is not clear. It's not here any audio from us.
Can we request
so change,
Professor Ajay Khanna sir to take this question? Khanna sir?
Can I answer,
Yes, sir. Please, sir.
The FNAC in papillary carcinoma is very much interesting. It's very must be differentiate from the follicular carcinoma. So the mainly things is often eye appearance. It is optical clearance of the nuclei and the overlapping of the nuclei may be present. And one more point is the nuclear groove may be present. This is really very easy to find out this papillary carcinoma. The nuclear grooves may be present, optical clearing, and often eye appearance may be present. And increase the ESR level also. Increase the ESR level, and also the inclusions of the reticular findings also may be increased. So these are the findings in the papillary carcinoma. And the sum bodies may be present.
So what is summum body? This question again to Dr. Guru Santappa.
Yeah, it's
They will
like
talk
what
about
we
scope
asked
of
for the,
disease.
yeah, papillary carcinoma, they will have the projections within the follicles. And as the tumor grows, the tip of the projections, which is the least vascular supply, which will go for necrosis. Once there is a tissue necrosis in a living body, there will be calcification over the dead tissue. That type of calcification, we call it as a dystrophic calcification. Means the calcification in a dead tissue in a living human being. So that is a dystrophic calcification. Those are depicted as microcalcification in a papillary process, which is typical of papillary carcinoma pertaining to thyroid, which is also seen in many other malignancies where there are projections inside a tumor. And to add to that previous question of what are the findings of FNAC in a papillary, one specialty of FNAC pertaining to papillary, this is the one malignancy where we can pick up FNAC in a secondary deposits when primary is occult. So even doing a FNAC in a lymph node with occult primary, we can diagnose papillary carcinoma thyroid.
So what are the one more questions I would like to ask? What is the content of Somoma bodies? PG is
It is
asking
nothing
the
but the
question.
calcification, dystrophic calcification in a papillary projection, which is a dead tissue in.
Some literature shows that amylasia substance may be present in the Somoma bodies. So I read it. That's why I like sharing of this.
Only a constant micro calcification alone.
Yeah.
Calcification.
So another pathological findings is papillary variants. The papillary variants are the pathological findings, the tall cell, columnar cells, and diffuse sclerosing, microcapsulated. So many the follicular variant, the papillary variants may be seen in the specimens.
As we rightly discussed, the papillary carcinoma, we have got a single layer of neoplastic cell, like a fibrovascular stalk with the optically clear cytoplasm. The chromatin material is marginalized to the periphery, giving the appearance of typical orphan Annie. And along with that, you will have pseudo inclusions and nuclear grooving.
And
yeah, that this question again to Dr. Paul. Is it mandatory to find out or categorize papillary carcinoma? Because there are some variants in this. So what are the variants of papillary carcinoma and how much they are important in managing the case? This question to Dr. Paul.
Yeah, so the classic type is when these papillary or finger-like projections are visible. And the most common variant is the follicular variant of papillary thyroid cancer, where the pattern is in follicles and not in papillae. So importantly for pathologists, they say if you see any papillae, even if most of the tumor is follicular, even if they see one or two papillae, it is still called classic papillary. For follicular variant, it has to be completely follicular patterned. The other variants which we see, they're all very uncommon, but of the lot, probably what the PG should know is the tall cell variant. Earlier, they used to be columnar and tall, depending on whether it was the cell height was 2 times or 3 times the width, they used to differentiate. But now the columnar has been removed, but it is basically the tall cell variant that we talk about. And the tall cell is more aggressive, less likely to take up iodine, and has a little poorer prognosis than the classic type. The follicular variant, being the most common, is even 20 to 30% of the overall papillary type. Has also slightly less iodine uptake and marginally worse prognosis than the classic type. The classic is the best prognosis. It takes up iodine the best. There are other variants like diffuse sclerosing variant, oncocytic variant, and they are very rarely seen. What the PG may need to know is classic with follicular variant most common and tall cell variant less common. I think this they have to know. I would just like to touch upon this findings in the cell, what is beautiful about papillary is because the nuclear features are diagnostic, just the FNA can give you a result, most common type. So doing an FNA well is very critical in thyroid nodule management to make sure you get a good specimen. And if you actually look at the cells there, you can see the orphan Annie-eyed nuclei. Orphan Annie was a cartoon character come in the old Mad comics, and she used to be drawn with the eye and no iris color. So it was just an empty eye. And that represents the nucleus of the papillary carcinoma cell. And the characteristic is that the chromatin, which is normally nice clumped and thick in the center, in papillary cancer, it gets dispersed. So dispersed chromatin causing it to appear optically clear. The other more diagnostic feature in the nucleus is actually the intranuclear cytoplasmic inclusions. Now we said there's nuclear grooving because the nuclear membrane becomes unstable and tends to increase in size and surface area, and then it undergoes grooving. So when it grooves, it actually pulls in some cytoplasm into the nucleus. It is not actually inside the nucleus, but it has come because of the grooving, and it has ingested into the nucleus. So when you do the slicing in histopathology, when you cut across the nucleus, that indrawn cytoplasm appears as if it is inside the nucleus. It's actually not inside nucleus, but appearance. But that is a very characteristic feature. It means the nuclear membrane is so unstable. So intranuclear cytoplasmic inclusions, which is actually a misnomer, is a highly diagnostic feature on cytology for papillary cancer.
Yes, sir. Thank you, sir. Now, Alex, are you in line? Alex?
I think he is also some audio issue problems.
I would like to say that.
Change, Jailal.
Jailal sir is
Jailal.
Yes, sir. Sir.
Welcome, sir.
Yeah, thank you, sir.
The FNAC features in papillary carcinoma, though we are not able to make a diagnosis of follicular carcinoma in FNAC, we need a core of tissue. What are the findings to say it is follicular carcinoma? The pathological features of follicular carcinoma. When will you see that?
By FNAC, sir?
FNAC cannot.
No, FNAC will not be able to do, and normally we don't even try to do a core biopsy when a suspicious of follicular neoplasm, and only when the histology, the reports which comes, it is because we need to go for the vascular invasion and the capsular invasion. Only when the tumor is invading the capsule or when the tumor is invading the vascular, and we will think sense of a follicular carcinoma. But there is a variety called encapsulated follicular variant of the papillary carcinoma, which is also known as a Lindsay tumor, which will comes under the good prognosis. And another tumor which will also come under the follicular is a Hurthle cell tumor. But to some extent, our when radioiodine nucleus, when the uptake scan is done, it will be able to hot nodule, it will be able to produce, and that will be able to make a difference. Otherwise, and preoperative diagnosing of the follicular carcinoma is difficult. But now the advance of the photography, which is to some extent it will be able to help us to say that whether it is we are leading with the case of the follicular carcinoma or the papillary carcinoma.
Thank you, sir. Having discussed ultrasound, thyroid function test, and FNAC, in this case, the report has come as papillary carcinoma thyroid with secondary deposits. So in this scenario, what are the other investigations you want to do? This question to Dr. Balaji Singh, other investigations to manage this patient.
That depends on the clinical examination, sir. Yes. We have to see if there is a nodule is small and there is a mobility, everything is present. Okay, then we have to obviously, as a routine, we have to do a X-ray of the neck AP lateral. One is to find out any microcalcific and other things. Number two, to know the vertebra. But this girl is 25, so not an issue. In elderly people, the X-ray is important to know any cervical spondylosis, such things are there, because positioning of the patient may cause a problem. Being a young girl, that's not needed, but X-ray neck, AP lateral, along with, as Sir said, the functional aspects of the T3, T4, and TSH, and direct laryngoscopy to assess the cords. Though she doesn't have any hoarseness, better to assess and for documentation purpose. As you all know, like patients, I mean, 1% of the population can have a recurrent laryngeal palsy due to exanthematous lesions which they get in childhood. That's what we normally teach, like measles, chickenpox can affect, and it may be compensated by the other cord, and patient may not have hoarseness at all. So we have to document that. Then, depending on the tumor, whether it is hard, if the carotids are pushed, if you suspect invasion, then comes the role for CT or MRI. Otherwise, there is no role for further investigation. Only when there is retrocessional extension or when you suspect invasion to the carotid sheath or to the adjacent structure or to the trachea, if it is all fixed, only then we'll go. But in this particular patient, I don't think it's needed because you said it's a small nodule. And ultrasound per se can pick up the lymph nodes. Thus, to assess the lymph nodes is not needed. Whereas, to assess the invasion and other things, I think CT and MRI can be done. Otherwise, the routine X-ray of the neck epilateral, then you have to do a direct laryngoscopy and thyroid function test. With that, I think we can plan further.
Okay, sir. Now this question goes to Dr. Kannan, Director.
Yes, sir.
So what are the other investigations you want to do in this case, sir?
Sir, when we consider... Yes, sir.
Thyroglobulin, or is there any role of PET CT at this stage?
PET CT is not needed. Only PET is needed in case of a recurrence. PET is needed in case of an unknown primary, or when the thyroid is the follicular cells have not taken radioiodine. In that case, they may be await for the FDG. Only in recurrence or in case of an unknown primary.
What's the point on serum, estimation of serum calcium and serum thyroglobulin?
Yes, sir. Serum calcium and serum thyroglobulin are needed.
Please do that, or
it's needed, sir. Preoperatively, we need to know the serum calcium and serum thyroglobulin level also.
And this question to Dr. Ramesh, surgical oncologist. What is your plan of management of?
So as far as the tumor markers in the pre-op evaluation of papillary CA thyroid, thyroglobulin assay will not have much value in the pre-op settings. Only in the post-op follow-up, especially in the setting of thyroglobulin, along with the antithyroid antibodies, we generally do it for the recurrence. I don't think any role for thyroglobulin estimation.
Thyroglobulin is not necessary.
And calcium also, I don't think any value here in the pre-op evaluation of the thyroid axis.
That's told.
So both thyroglobulin estimation and calcium estimations are not mandatory in this case.
Yes.
Likewise, the role of PET CT comes only in the post-operative follow-up management, not for prior diagnosis.
PET CT, the role of PET CT is very clear. So the pre-op evaluation of well-differentiated carcinoma thyroid, there is no need for PET CT. PET CT is indicated only in the post-op setting, in the recurrence, when the residual disease is not taking up iodine, that is radioactive iodine negative tumor. We use this PET scan to pick up the recurrences, especially the localizing study as a part of localizing studies. In radioactive iodine, negative thyroid disease. Sometimes due to stunning effect and other disease, sometimes the thyroid cancers, the well-differentiated thyroid, they will not take up radioactive iodine. In these settings, the PET scan will be very useful. And of course, it is very useful in the medullary carcinoma, metastatic workup also in the pre-op and post-op setup, especially the PET gallium-68 scans.
Otherwise, sir, PET CT actually, if the post-op thyroglobulin levels are very high.
Yes. 10 is 10. Thyroglobulin level more than 10 nanogram with negative uptake of radioactive iodine. That is called the 10 is the
syndrome.
PET CT is indicated in TG positive whole body scanning negative cases.
Yes, sir.
Thyroglobulin elevated.
Right.
Thyroglobulin.
Yeah.
Thyroglobulin elevated, radioactive
You can go
iodine
for
negatives.
Yes.
Now, Ramesh, what is the, tell me the line of treatment, single line, what is the plan for this patient?
So, particularly in this case, it is a papillary thyroid. We practically take it all both bilateral cervical lymph node as a metastatic disease. Then the treatment of choice would be the total thyroidectomy with central compartmental neck dissections, with bilateral functional neck dissections, or MRND, what is called as MRND type 3. That would be the ideal options in this case.
Now, having said total thyroidectomy is the treatment of choice for thyroid cancer, that to papillary cancer with the bilateral neck nodes, you will go for central neck dissection with lateral MRND. Why total thyroidectomy is indicated in this case, even though the nodule is confined to only one lobe? Why should you remove the opposite left lobe? This question to Dr. Alex or Dr. Sahai and Segan. Both are there or not?
Oh, both are have audio problems, sir.
Okay.
So
Dr.
obviously,
Prasantappa, you are telling Ramesh?
so obviously the nodes of bilateral nodal involvement, it is always total thyroidectomy. If there is a even if there is a unilateral node involvement, then also we will go for a total thyroidectomy. So it is only in select in situations like unilateral thyroid lobe involvement without any nodal disease in a low risk category, you can attempt a lobectomy provided the nodules are less than 4 centimeters in size without any extra thyroidal extensions, and the histology also belongs to the low risk category like classical variants. So these are the select situations where you can go for a conservative or what is called as ipsilateral lobectomy with hysterectomy. But we have always have a reservation against doing these conservative procedures. Though many guidelines, ATA guidelines recommends ipsilateral thyroid lobectomy with hysterectomy in select situations. Whereas the Japanese Society of Endocrine Surgeons, they recommend total thyroid in all situations. They have their own justification, and we have also have our own justifications. Because the first echelon of the follow-up, especially with the follow-up thyroglobulin estimations, post-op radioactive iodine uptake studies, all these are feasible and possible only if you knock out the thyroid completely. You can have a clear follow-up. Number two, the local recurrences are very common. If the local recurrence occurs in the central nodes or opposite nodes, the revision surgeries leads to the much more complications in the form of recurrent injury or hypothyroid gland injury. See, after all, why people promote or advocate conservative surgeries for fear of the injury to the recurrent laryngeal nerves and parathyroid glands. But what we say is the recurrence redo surgeries has got a more chances of injuring these vital structures. That is what, and follow-up is also very difficult without knocking up the total thyroid glands. This is the for and against for conservative versus total thyroidectomy.
Right. So to sum up, why total thyroidectomy in a nodule confined to one lobe? It is papillary carcinoma is always notorious for multicentric origin, huge intrathyroidal lymphatic spread. To assay the thyroglobulin level in the post-operative period, likewise the whole body scanning, everything has to be done only after knocking the entire lobe of thyroid. And resurgery in thyroid is very difficult because it is more prone for injury to recurrent nerve or parathyroid. So for these reasons, we always advocate total thyroidectomy for a papillary carcinoma, even though it is confined to one lobe. Now, this question to Dr. Paul: what is the pattern of lymphatic spread in thyroid cancer? Which is the first echelon node to get involved in thyroid cancer? From there, where it will go? Dr. Paul?
So classically, the thyroid spreads to the central compartment first, that is the ipsilateral paratracheal group. So the central compartment is in 3 areas. One is pre-laryngeal or the delphic area, pre-tracheal in front of the trachea, and paratracheal, which is actually arranged along the laryngeal nerves. So from most of the lobe, the tendency is to spread to the central compartment nodes, which will be paratracheal because most of the lobe is sitting laterally. Two small exceptions is if it's arising from the isthmus or pyramidal area, they may go directly to prelaryngeal or pretracheal, which is still central compartment. And the other exception to that is from the superior pole, it can go directly to the level 3 node in the lateral neck. But for postgraduate purpose, it's good to remember the general dictum that the first point of spread is to level 6, which is the central compartment nodes. Then it goes into level 3 and 4. These are almost equally involved. From 3 and 4, it goes up to 2 and laterally to 5. So that is the general route of spread. From the central, when there's very extensive involvement, the central compartment nodes can go down to involve even the upper mediastinal nodes in the superior mediastinum.
So you'll never, very, very rare to have level 1 node getting involved in thyroid.
Practically never involved in thyroid, especially papillary. So which is why the old MRND was deemed too much 1, 2, 3, and now we actually call it either a selective neck dissection or a functional neck dissection. So when we do, say your patient comes with if in this patient, supposing the nodes are palpable in level 3, when we do a selective neck dissection, we would take 2, 3, and 4. And we definitely don't go towards 1, and even 5 needs to be removed only if there are nodes detectable during surgery. You don't have to routinely dissect 5, and you must try and preserve all the structures as much as possible. The important concept is that in squamous cell carcinoma, the tendency for lymphatic emboli to set up separate requires that the entire field needs to be removed. There again, the concepts are changing. But in thyroid cancer, lymphatic emboli do not set up new focus of tumor. It only grows within the node. So the aim must be to remove the nodes without damaging the normal anatomical structures, which includes the vessels, the nerves, the muscles of the neck. Yes.
The recurrent cases, we get the level 1 node also involved. And the second time when you are going there is a possibility of involvement at the level 1 is also high.
Level 1 node.
Yeah. So once you have dissected, then you alter the drainage pattern. So then you can get anywhere. We've even exceptionally, we have seen even axillary lymph nodes, which is very exceptional. We have seen even tumor in the skin for papillary cancer. These are all secondary involvement after a primary dissection, and then abnormal channels are involved.
So the first echelon will be central group of lymph nodes, ipsilateral central node, then contralateral central node. Then it will go to ipsilateral lateral and then contralateral. I mean, the pattern of lymphatic drainage in thyroid cancer.
Yes, yes. Ipsilateral central. There is a small percentage which can even go to contralateral central. So this is a slight issue of debate. When we are doing central neck dissection for a known cancer, it is maybe better to do both central together rather than if there is no to do only the ipsilateral. If there is also the question is, are we going to do prophylactic? So if you have a lateral node which is involved, you assume that the central is already involved because that is the pattern of spread. We do the central always when we do the lateral.
Thank you, sir. Now this question to Dr. Kurusantappa. We have discussed the total thyroidectomy for all preoperative diagnosed cancers, and for lymph nodes in the lateral neck, as oncologist said, modified radical neck dissection. But many of the oral cavity lesions with the proven secondary deposits, we will go for radical neck dissection. Whereas in thyroid malignancy, we are going for modified radical. Why this difference? What is the rationale?
The rationale in thyroid malignancies, like what was discussed just now, the involvement of nodes. In thyroid, it is from 3 onwards. It is the commonly involved nodes. To add to the description which you gave just now, if for a postgraduate, if it is asked what are the nodes commonly involved thyroid malignancy, it is a 3rd and 4th or the 3rd. If it is asked pathologically, what are the common nodes which are involved in thyroid malignancy, it is a paratracheal or Delphian nodes, pathologically. Coming to this, why the fond of doing functional or modified neck dissection in thyroid malignancies versus the head and neck malignancies, where still we do practice doing radical neck dissection, is again the pattern of nodal involvement in thyroid malignancies. The first group is unlikely to be involved. The second level nodal involvement in thyroid malignancies is around less than 10%. The third onwards, third, fourth, and sometimes fifth, and the central neck node involvement is more than 70% of the cases. So this is the one reason where we stick to the modified neck dissection, which amounts to the safeguarding the important structures in the neck in the form of IJV, sternocleidomastoid, or accessory nerve. So it is a pattern of involvement. Compared to oral malignancies, which are squamous cell carcinoma deposits, the chances of involving from level 1 to level 6 is very high, versus the thyroid malignancies, where from level 3 onwards, 3, 4, 5, and the central nodal involvement chances are very high, more than 70% of the cases. So this is the one reason where the limited dissection of the lymph nodes is feasible and acceptable in thyroid malignancies, if you are comparing with oral malignancies. One. Second, the doing unilateral or bilateral. The thyroid malignancies, even though the sir gave the explanation of intrathyroid spread and intrathyroid lymphatic structure, even though the disease is on one side, it is very unlikely to have an involvement of the opposite neck nodes whenever we are talking about thyroid malignancies. It is the same side of the neck which is commonly involved than the involvement of bilateral neck nodes. So both these reasons, even though the intrathyroid spread is there, because of these 2 reasons, it is better to have the functional pattern of neck dissection rather than a radical, which we do for oral malignancies, which are commonly squamous cell carcinomas.
Sir, mute.
The next question to Dr. Jayalal sir, for the benefit of postgraduates, tell me the difference between a classical radical neck modified radical neck dissection. Jayalal sir. Dr. Uttarakumar. Dr. Uttarakumar.
Now Jailal sir is ready, sir. Jailal sir.
Yeah, sorry.
Sir, the main difference between radical neck dissection and modified radical neck dissection, what are the structures preserved?
So the modified neck dissection, we preserve. In radical neck dissection, there is a 3 structures in front of us when we are trying to remove. Is a sternocleidomastoid, accessory nerve, and the internal jugular vein. And again, it comes as a modified standard radical neck dissection. Depending upon A, B, C, the 3 types, we preserve the 2 or 1 or any sacrifice or preserve all the 3 structures. When it comes to the modified radical neck dissection type 3 or the functional neck node dissection, all the 3 structures are preserved. So here only the functionality of the nerves and the muscles are preserved. But otherwise, apart from that, whether we are doing a radical or modified neck dissection, the removing all the lymphovascular tissue, the fatty tissue, and in continuity removing that, there is no obvious difference in that. That is why now the terminology, now it's much important terminology is a comprehensive neck node dissection. Whether you are, it is only on preserving these 3 structures, which depends upon that radical or the modified radical neck dissection. But the ideal terminology nowadays, in some of the textbooks started using, is a comprehensive neck dissection. But depending upon your structure, you are preserving that spinal accessory, sternocleidomastoid, and internal jugular vein.
Thank you, sir. Again, this question to Dr. Ramesh. We have got bilateral neck nodes. Which side you will deal first? MR&D on left side or right side? The nodule is on the right side. Nodes are on both sides. Which side you will do MR&D first? Is there any rationale?
So here, I will choose the side irrespective of the side, the node side of the nodule. So I will rather choose depending on the lymph nodal extent, the lymph node mass, the fixity of the nodes, which side there is a heavy number of lymph nodes, which side there is a heavy infiltrate, hard nodules, big nodes, which obviously with the chances of infiltrating the IGV, where if I see reasonable reasons where this side may end up with the sacrifice of internal jugular vein, or chances of injury to the internal jugular vein is more due to the big nodes or the fixed nodes, then obviously I choose that side first. So that even if some injury happens to the internal jugular vein, or I have to sacrifice the internal jugular vein, we can always complete that dissection on the particular side, and we can postpone the neck dissection on the contralateral side for another 4 to 6 weeks. So that is my idea.
Thank you, Dr. Ramesh.
Can I just add to this?
Yes, please, sir. Please.
Yes,
sir, for overall the surgical principles is whenever there are it goes to any surgical disease, when the plan is doing on either side bilateral disease, the first thing should be on a place where we are trying to preserve some important thing. That's where we should start the first one. This goes without saying for any area anywhere in the body.
So my point is, see, suppose we are taking the minimal disease side, and if there is a inadvertent or unexpected injury to the internal jugular vein, then we cannot venture into the neck dissection on the opposite side. So, which will lead to the further progression of the disease and further spread of the disease. So, we always prefer a dissection on the side where the volume of the disease is high, and the chances of injuring the IJV is also high. So we always prefer that side first. So that is our rationale.
Sir,
see, as far as the papillary thyroid cancer is concerned, the lymph node spread is not directly related to any prognostic significance of the disease. You can always remove the nodes. Unlike in squamous, previously we were discussing about the difference between the oral cancer dissection and thyroid cancer dissection. Here in thyroid cancer dissection, we hardly find any difficulty and rapid progression of the disease, soft tissue involvement. So we can always wait and do the dissection on the opposite side for 4 to 6 weeks afterwards.
Sir, previous question you had asked, what is the why not R&D, why M&D in thyroid? To add to the points which I explained, 2 more points are the perinodal spread in a thyroid malignancies is less likely, 1, and there are less likely of the lymphovascular emboli in thyroid versus squamous cell carcinomas. So basically, these 2 microscopic findings will also substantiate of doing minimum for neck nodes in thyroid malignancies versus the oral malignancies. These 2 important, the microscopic.
Yeah, exactly. Moreover, we cannot simply equate with the squamous cell carcinoma of the oral cavity with that of the thyroid. An indolent, less aggressive papillary carcinoma of thyroid. See, squamous cell carcinoma, if you miss the bus, if you miss the chance, then it will be disastrous. The nodal recurrence in a squamous cell carcinoma, if it is improperly done, or if you miss, or if you have not done adequate surgery, then it is the end. Whereas in carcinoma thyroid, the papillary, especially in papillary carcinoma, you can always go for a revision surgeries. It is not going to affect the overall thyroid. Whereas carcinoma tongue, say the oral cancers, if the nodal disease recurs, there is no way, even in spite of repeated no surgeries recurrent, the revision surgeries won't help. Revision and the repeat radiations will not help. It is a very dismal state of affairs. So it is basically, it's a very highly aggressive disease. You just cannot compare the squamous cell carcinoma with the thyroid cancers.
Moreover, the lymph nodal involvement does not have any prognostic value in thyroid cancer.
As far as papillary CA thyroid, or for that matter any well differentiated carcinoma thyroid, the lymph nodal involvement does not correlate with the prognosis or overall survival of the disease. Whereas in medullary carcinoma, the lymph nodal involvement has got a very good link to the relation to the prognosis of the disease.
Now, Dr. Paul, what is your comment on this bilateral neck nodes? Which side you will do first? Because we have got two different answers, one from Dr. Ramesh and one from Dr. Gurusantapa. What is your comment, sir? Paul?
Yeah, I don't. I think different pathology may have, as Ramesh was saying, that you can't equate squamous with thyroid. I must say, in our experience of so many hundreds of neck dissection, we have never had to stage it for thyroid cancer. For a papillary stand, the kind of case we are talking about, I think there is there is really no problem in doing both dissections at the same time. Now, as Dr. Ramesh was saying, in case you find a problem with your IJV on the more affected side, then should you go to the opposite side? And I must say, in our experience, we have not stopped. We always go and finish it at the same time. The point he's trying to make, the question is, if you have bilateral IJV injury, what is the problem to the patient? And if you occlude both IJVs, you will get significant cerebral edema, which, but even that can be managed. We have had one case where we had to do, because it was a poorly differentiated thyroid cancer, extensively involving the carotid sheaths, where there was bilateral IJV involvement. But if you take, generally, if you take a focal segment of IJV, the wonderful thing about venous anatomy is very forgiving. Venous anatomy is highly variable, and it always has small channels all over the place. And the fact that the tumor has earlier infiltrated it and blocked its flow means that already alternative channels would have opened in various areas. They will go into the vertebral circulation, they will go in the lateral neck circulation, go through the shoulder and still drain. So practically, you can even get away with bilateral IJV excision. That's what, even in literature, it's documented. But your patient may have transient cerebral edema, for which you have to be prepared for a post-operative ventilatory and anti-edema measures management. Now, if the rare situation where if the edema is significant, is not settling, you may have to also think of a venous reconstruction, which can be done either the primary setting or a secondary setting. Now, so in our experience, we have had one case go through transient cerebral edema and still come out well. But I don't think for the average thyroid cancer lymph node metastasis, especially well differentiated, that this is actually an issue. I think we are borrowing this issue from more aggressive pathology like, as he said, squamous and poorly differentiated tumors.
Sir, both the answers can be correct only. It depends upon the given situation. Either you can go to the less involved area, save the thing and go to the more involved area, or aggressively go to the more involved area and try to save in the less involved.
My answer was, we should start in a place where you have decided to preserve something. That should be the first site to be tried. Where you should, at any cost, you should preserve something on one side. Then go to the opposite side, where even if you sacrifice, nothing happens, because already you are preserved on one side.
Thank you, sir. We'll move on to the next question to Dr. Uttara Kumar. During surgery, while performing total thyroidectomy, we are much bothered about two important structures. One is rectal nerve, another is parathyroid. Now, how will you try to preserve the rectal nerve? What is the strategy you will follow while doing surgery to preserve the rectal nerve? Dr. Uttara Kumar. Dr. Alex, anybody who has not attempted at all? Dr. Sahayan Baraj.
Sir, எல்லாத்துக்கும் Zoom app and audio issues, some issues, sir. That's why they are not participating. So that's manage with our faculties.
Okay, Chandra.
Thank you, sir.
Dr. Jailal, sir.
Yeah, I mean, it is one of the important tasks ahead for any surgeon who is going for thyroid surgery. From the old concept of don't go and look for it, now we always go and look for it, identify it. We know for sure that what are the points which are more critical areas where it is crossing, and when they're crossing the inferior thyroid artery. So we identify the vessels. I mean, one of the steps to be preserved is we identify the vessel and come and very close to the when it comes to the branches, and each branch is separately ligated until it reaches the Berry's ligament. We will look for it and trace the recurrential nerve. And we don't have a setup of the nerve stimulator, but clinically it is mandatory, and we make it as a routine. But all cases, we visualize the recurrential nerve for its entire course, and then only we will proceed and cut other stretches. So we know the critical points where it is possible it can get injured, and we also know the pathway, and with that we can look into that, and it is possible for us to identify the recurrential nerve and preserve it.
Suppose there is a bit of tumor tissue encircling the recurrential nerve at the point of entry, and preoperatively the vocal cords are normal. Will you leave behind the bit of tumor tissue, or you will sacrifice the recurrential nerve?
I will always try to leave that, not take the risk of voice, because if it is comes as a near totally a small tissue, we have option of radio ablation and other treatment modalities available. So we'll get probably oncologists with oncological clearance, they will still go ahead with that. But as a general surgeon, I will try to definitely, if it is there, I will try to leave behind that small bit of tissue which is there.
Jailal sir, I would agree with Dr. Jailal sir, because as long as there is no preoperative nerve involvement, there is no nerve pelvis, and if the tumor is just over the abutting the nerve or small rim of tumor tissues around the nerve, we can always leave the rim of tumor tissues around the nerve, and that can be managed very well. The post-operative, your radioactive iodine ablations and the TSH suppression will always take over that. After all, it is with the hope that it is a small indolent disease, slow growing disease, less aggressive disease. You can take that chance always. Otherwise, if the nerve is already involved, if there is a complete paralysis preoperatively, then I can always go for a oncological orgiro resection. I will dissect that nerve also along with the tumor. That is our.
Thank you, Ramesh.
So one of my question, like most of the endocrine surgeons talk about tubercle of Zuckerkandl. How? What's your we have tried finding it, and with seeing that, identifying it, we can very much preserve the nerve as well as the superior parathyroid. So that's the thing many endocrine surgeons tell. So what's your opinion, Marubani sir, Valim sir, and others?
So regarding parathyroid,
tubercle of Zuckerkandl. Tubercle of Zuckerkandl, they say like condensed thyroid tissue on the lateral and superior aspect of the thing.
Dr. Paul?
The many endocrine surgeons insist on that.
Yeah, sorry, I'll.
Yeah.
That actually, when there is tumor in the tubercle, is when it tends to involve the nerve or near the Berry's ligament and tubercle.
Yeah,
and regarding the previous question, fully correct that in a case of differentiated thyroid cancer like classic papillary, if there's tumor engulfing the nerve and it's functioning, you must leave that tumor to preserve function, because it doesn't make a difference to long-term survival. You can take care of it with iodine and other treatment. The only rider to that is if it is poorly differentiated or a aggressive variant, then it is difficult to control the tumor in that location. And in a rare circumstance, if it's completely engulfed and there's tumor in the trachea, it may be preferable to actually sacrifice the nerve in poorly differentiated cancer. So you have to differentiate. The treatment is slightly different based on the type. Here we are discussing well differentiated, so that's fine. Now regarding the tubercle, it's actually something that was not appreciated. Like when we were all training, I think nobody understood this tubercle. It's an anatomical structure that has been described more recently, and we have done also detailed studies, many groups have done, and about 60 to 70% you can actually see a gross tubercle which projects posteriorly. The relationship of the nerve is posteromedial to the tubercle in 93% of cases. So it is used in the 70% where it's significant, it will override the nerve like that. So you have to actually dissect the nerve out from under the tubercle. We're doing a proper nerve dissection. In those cases, you will actually see it and you can separate the tubercle from the nerve. Also, the superior parathyroid sits on the head end of the tubercle when it is there. Sometimes the tubercle itself can be diseased, and that's when it becomes difficult to handle either with nodal hyperplasia or with the cancer. Rarely cancer will involve the tubercle area. So tubercle of Zucker-Candle is an important structure when you want to do a complete total thyroidectomy.
Correct, sir.
Balaji sir.
Yes, sir.
Gurshadappa here, sir.
Hello, sir. Fine, sir.
Yes, sir. Namaste. Namaste. Sir, sir, to add to the Dr. Paul's information about tubercle, sometimes this can be mistaken for a lymph node, paratracheal lymph node. This tubercle of Zucker-Candle. It is in many cases it is present. It looks like exactly like a paratracheal lymph node in the upper part of the gland in the posterior side. And if you have already identified the recurrent laryngeal nerve lower down near the branches of the inferior thyroid artery, and if you are tracing that recurrent laryngeal nerve proximally towards Berry's ligament, before the Berry's ligament and between the inferior thyroid artery branches and the Berry's ligament, this is the tubercle which you may come across, which is not separable from the thyroid lobe. That is how we differentiate between a lymph node and a thyroid tubercle. So it is between the Berry's ligament and the branches of inferior thyroid artery. So, and second, to safeguard that recurrent laryngeal nerve, usually when I do surgery, I identify inferior parathyroid and the recurrent laryngeal nerve together. So if we can identify the small branches of the inferior thyroid artery and tackle them by bipolar cauterization and maintain good hemostasis at that point in the lower part, definitely both of them can be identified and the nerve can be traced upwards. This is the one important point we should consider. One. Second, if your surgery is on the right side, invariably the nerve will be little far away from the tracheoesophageal groove. So try to find out the nerve at that point and then trace, compared to the left side, which will be abutting.
Thank you, sir. Now this question to Dr. Paul. Like recurrent nerve, we are giving much importance to another structure, parathyroid. On table during surgery, how will you identify parathyroid, whether it is a lymph node or fat or parathyroid? How will you differentiate these three structures? Sometimes you will get confusion on the table. How will you on table confirm whether it is parathyroid or not?
Thank you. So it's like the success of a hotel, they say, depends on three factors: location, location, location. I don't know if you've heard that. So the same concept is there for parathyroid. Success of identifying a parathyroid is location, 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 especially in regards to the superior, because it is more predictable. It is within a centimeter of the nerve and ITA. So what we do first is, as was pointed out, you first identify the inferior thyroid artery after mobilizing the lobe. Then you see where the nerve crosses it. And then you come to the tubercle. When you mobilize the tubercle, you can actually find it abutting the tubercle. If there is no tubercle, sometimes there's no tubercle, and you're directly seeing the nerve and ITA crossing, superior to it, you will find the parathyroid in a location that is posterior to the plane of the nerve. That is the location. So the problem is that sometimes you see fat around the thyroid and you're not sure is it parathyroid or is it fat in the superior area, because there very rarely there are lymph nodes to confuse. So mainly you have to differentiate, is it fat or is it parathyroid? And we know that already the parathyroid often has a fatty hood. So that the color is very important. So the trick is, don't get misled by the first thing that you see. Often the first thing you see will be the fat, parathyroid fat. So you need to be very careful about the color, which is a pinkish brown. And then you will be able to see fine vessels on the surface, and you may be able to identify the supplying vessel. So first is location, then is to differentiate the color. Fat is always yellow, but the parathyroid is almost always pinkish brown. But some parathyroids can be not so pinkish brown, slightly less colored. So that's when differentiation is fat. With fat is slightly difficult, but the color often is the best indicator, and the supplying vessel. Now the inferior parathyroid has more variable location, so it's a little more difficult. When you mobilize the inferior pole, we look at the thymus. A good way is to, when you're mobilizing the inferior pole, to look at the capsular surface and see whether you can identify a parathyroid. It may be flattened on the thyroid. That's when it becomes difficult. It's not separate, it's against the thyroid. And if the thyroid is nodular, it will be even more flattened because it would have stretched out the parathyroid. So I have a term called the Rumali roti parathyroid. Sometimes you have a nodule and the parathyroid is actually stretched, curved on the nodule in the inferior part of the gland. So you have to be careful of all these tricks that the parathyroid anatomy plays. The classic description is in the thyrothymic tract. So as the thymus, which is likened to a thumb coming from the mediastinum towards the thyroid, the classic location of the parathyroid is under the nail of the thumb. That means it's just under the fascia that bridges the thymus and the thyroid. If you just lift the fascia, that is the common location. But being inferior, it's highly variable. It can be on the surface of the thyroid, it can be in the paratracheal groove, but the plane of the parathyroid is usually anterior to the plane of the nerve, unlike the superior, which is posterior to the plane of the nerve. That is a good localizing tool. So using these points, we can identify the parathyroid.
Thank you, sir. So superior parathyroids are mostly 80% of the time they are having constant location, whereas the inferior parathyroid is more prone for ectopic locations because of the long descent. So location of the parathyroid is more important in identifying the gland. Now we'll move on to the next question to Dr. Kannan, Director MMC.
Yes.
The parathyroids, 4 parathyroids are getting avulsed and seen in the specimen of thyroid. How will you manage that situation?
In a total thyroidectomy,
thyroid.
Both the pairs are removed, or
all 4 parathyroids are in the resected specimen of thyroid.
Yes, sir. When you remove all the parathyroids, one of the parathyroids should be mixed into pieces and it should be implanted into the sternomastoid, or in case of a medullary carcinoma, in the non-dominant brachyradialis muscle. So auto transplantation should be done. When you can identify the parathyroid.
You make multiple minute bits and make packets in the sternomastoid, put it into that. Or yes, as you said, if it is medullary carcinoma, it can be implanted in the non-dominant forearm. Thank you, sir. Now the next question to Dr. Ramesh again. If the thyroid cancer is just infiltrating the perichondrium of trachea, locally advanced, what is your line of management?
There is a just perichondrium.
Dr. Ramesh?
Yes, sir, I am. If the perichondrium is just involved, I will try to save up the tissues as far as possible. If there is any inadvertent injury or sometimes I have to go for a a window resection of the trachea, that also I will not hesitate to do that to achieve the clearance of the cancer. So the window dissection can always be managed with a strap muscle flap or some other muscle flap from the adjoining muscles. So that can be managed. So that is the thing.
So pericardium alone is involved, just to shave off the involved portion.
During the time, during sometimes so what appears as a pericardial involvement while doing the dissection, sometimes we may end up with the dissection of some window dissection of the tracheal wall itself. So in that situation, you can go ahead with the window, complete the window resection of the trachea. That means a part of the tracheal wall, and we can always cover up with the muscle flap, local muscle flap, the strap muscles.
One point. Can I add?
Yes, sir.
Yeah, one point of the resection at this point. If your plan is to shave off this thyroid from the perichondrial environment, it is better to have a knife dissection rather than the diathermy dissection.
Yes. Yes,
Because this is the point you should keep it in mind. It is a knife which does better work without making a rent which is not noticed on table. Otherwise, if you use a diathermy for this purpose, post-op probably the person may develop emphysema, and later we have to do probably tracheostomy. This point
fully agree, sir.
Okay, sir. Now this question
sorry, there is a dissection of trachea. Obviously, will you do a tracheostomy or not, sir?
The point is decision is to shave off the tumor from the tracheal rings without a resection. Probably there is no need to do tracheostomy.
Dr. Ramesh told the ring is involved, ring can be removed. I think if the ring is removed, you should have a tracheotomy. Tracheostomy is
not in all cases, sir. Only if in tracheal resection also, if the resultant gap is more than 2 centimeters, if you are not able to approximate it, you can put it as a tracheostomy. If it is possible, primary suturing can be done even after a tracheal rings resection. What's your comment on
so only if it is a circumferential dissection, then only we will go for a end-to-end kind of anastomosis like thing. If it is only a part, only a flap, only a small the window resection, we will not go for a resuturing, sir. We always go for a flap frequency. As sir already said, if the defect is in the anterior or in the midline, then I will simply convert it into a tracheostomy. If it is the posterior lateral aspect, then I will try to cover up with the muscle flap. That is the idea. If it is small defect, you can always wait, sir. In the post-op, if there is any difficulty, we can always do a tracheostomy.
Correct.
According to the literature, what is mentioned in the books, theoretically you can resect out 4 to 6 rings.
Yes.
And you can do an end-to-end anastomosis after mobilizing the larynx and the trachea.
Both suprahilar and inferior.
Yeah, you have to mobilize. You have to mobilize whole of the laryngopharyngeal complex and lower down up to the mediastinum, and you can primarily resect out 4 to 6 tracheal rings and do an end-to-end anastomosis theoretically. But practically, what we do, we take it up to 2 the ring resections and do an end-to-end anastomosis in practice.
In practice, up to 4 rings only we can go, sir. For 6 rings, you have to go for the release of the trachea from the hilum. So that is a very difficult aspect. So most of the time, you will be able to do only the suprahilar release. The infrahilar release part is very difficult, for which you have to open the sternum, everything. It's a very difficult procedure. So we just we will not go beyond 4 rings.
Correct.
So this question to Dr. Jailal sir, for the benefit of postgraduates, what are the important complications you will anticipate in MR&D, especially on the left side? Dr. Jailal?
Yes.
Apart
from the inadvertent injury to the nerve or injury to the vessels, in the left side it is more common. If it is possible, of the thoracic duct injury is also a common issue. And when the thoracic duct injury, if we can locate on the table, it is sometimes when we will be able to even see that it's a on the table that can be switched. And if you are missing it out, and when we are seeing a drain, and again we go by the volume of output, and if the volume is more than 500, and even after metabolic control and the carbohydrate control of the diet, and if it is persisting more than 500, it is better to go and reopen, check and clip it, or ligate, mass ligation has to be done. If it is less than 500, and it is always possible, it will reduce. The one thing we must be very careful, we should not put a suction drain there. If you put a suction drain, the volume will be more. It is an ordinary drain. If it is less than 500, conservative management, and more than 500, we always go for a re-exploration and clipping that later. That is one of the complications which you can get, apart from the routine complications, the usual complications you are expecting.
Yes, sir. Now we'll move on to the next question to Dr. M.J. Paul. Interestingly, the esophagus will never get involved. Am I right? Or you want to make any comment on that?
Yeah, no, the esophagus also can get involved. It's much rarer than the trachea. So we call it aerodigestive tract involvement. So even from the tracheal, I just make a few comments. We recently assessed 22 cases we have done of laryngotracheal resection. So there, the important thing is to know about what's called a Shin staging. Grillo was the sort of father of the tracheal surgery, and his group, which is goes by the name of Shin. As you said, if the tumor is involving only the superficial, then a shave is the best. If you do, and that doesn't make a difference whether you resect or not, you can follow it up with post-op radiation. But if there is transmural involvement, then you must do a tracheal resection. And usually you can get away with a trachea and lower part of the cricoid, cricotracheal resection. And very rarely the thyroid involves more than a few rings. So, and Grillo showed, basically this group showed that the tumor goes only directly. It doesn't go lymphatically into the mucosa of the trachea. So you don't need a big margin, just a 1 millimeter margin is enough. Even if you have a microscopic positive margin, it doesn't make a difference. It will respond to treatment. So they do very well. So if you've got transmural involvement, like you showed in the picture, you must do a tracheal resection. And we tend to go by centimeters, because when it's all involved like that, you can't make out the rings. So we go by length, and 4 centimeters length can easily be bridged, and you can drop the larynx on top and mobilize the trachea below and close it. It's a very good procedure because it is fantastic palliation, and we've had excellent results with this procedure in 19 cases. In 3 cases, we had to go on to do a laryngectomy because actually the cord was involved, or it was involving the larynx. Now the question, sorry, you were asking about esophageal involvement. Yeah. So about 3 cases, we've actually had to do partial excision of the esophagus. Now the esophagus being a muscular tube and quite elastic, it will take partial resection without a problem. So when there is direct infiltration, many times it's just the superficial fibers of the muscle of the esophagus, and you can take an extra mucosal excision and just close the muscle over the mucosa. There's no problem. Rarely you have to do a full thickness excision, but even then you can mobilize the esophagus and close it, no problem. Only once I have had to do a complete circumferential excision of the esophagus, but even in that case, we managed to actually mobilize and pull it for an end-to-end anastomosis in the neck without having to do gastric pull-up. That is a very rare situation where you may have to do that. So that is for esophageal involvement.
Sir, how often it's common in well-differentiated cancers to have esophageal involvement? How often it's common in well-differentiated cancers?
No, in well-differentiated, it's very rare. What I'm talking about is mostly variants or poorly differentiated. But even in well-differentiated, we have seen superficial. It's basically they come very late. So,
especially in the recurrent cases, when they already operated and they are coming again, there is a possibility involvement is there.
Okay, so this question to Dr. Gurusantappa. Having done a beautiful total thyroidectomy with bilateral leg dissection and patient is discharged, what is the advice, or how will you follow up the patient post-operatively?
First thing, we need to have a good histopathological report. We should know what is the histopathology report. Is it well differentiated papillary CA or poorly differentiated? And what is the other details pertaining to the primary? Is there any extra thyroidal spread? Are there any lymphatic emboli? And second, pertaining to the nodal status. Is there any perinodal spread? Because the number of nodes is not important in thyroid cancers. So it is only the nodal involvement or there is no nodal involvement and an extra nodal spread. So with this report, yeah, if it comes as a papillary CA, then they need to be followed up. The first thing as a treating surgeon, we should know that we should not start them on suppressive thyroxine treatment. We should not. So we have to plan for the one nucleate scan, the testing first. Depending on that has to be done after 6 weeks, so that we will have a raised TSH levels. So depending on the report, the nucleate scan report, we'll find out what is in the primary disease area, what is the residual disease, so-called residual disease, in spite of doing everything, total thyroidectomy. And is there any disease left in the neck, starting from base neck till the root of the thorax. And if you are suspecting, for example, in other malignancies, if you are suspecting the extra areas, the other areas of metastatic possible deposits, we should have a whole body scan if there is a suspicion. So otherwise, depending on this, the nucleate, the person will calculate the total dose and the person has to be submitted for ablative dose of I-131. This has to be done. So after that only, we need to start the patient on a suppressive dose of thyroxine supplementation. And at the same time, after getting the histopathology report, it is better to have a IgG levels as a base level, so that will help us during the next follow-up before doing a second nucleate scan, which will be planned normally after 6 months. It will help us, the IgG levels follow up, whether the disease is controlled or the person is developing disease either in the loco-regional area or a distant area. That will definitely give some ideas in well-differentiated malignancies, IgG levels. So if within first the I-131 nucleate scan and ablative dose, everything is under control, invariably the person will be submitted for the second the cycle of nucleate scan after 6 months. And before that, 1 month prior, we need to stop this suppressive dose of eltroxin and submit the patient. If there is no residual disease, everything is fine with a second, the diagnostic nucleate scan after 6 months, nothing to be done. Even if there is the slightest residual disease, either in the loco-regional area or a distant area, again, the nucleate person will give a second ablative dose of I-131. And invariably, the maximum the dose required for a person in a well-differentiated thyroid cancers will be third or the fourth cycle. By that time, everything will be settled. Maximum 2 cycles, most of the patients with a good surgical treatment, they will settle with this. So the follow-up, first, don't give any drugs, have a nice histopathology report, don't give suppressive dose of eltroxin, submit the, get a IgG levels. Yes, sir. This is the standard protocol for well-differentiated thyroid cancers, because these are the well-differentiated thyroid cancers. It will be
post-op specimen. You can categorize that low risk, medium risk, intermediate risk, and high risk. In low risk,
we are talking about a case where there is a nodal disease, where there is a nodal, like what we have given the example here. Once there is a nodal disease, irrespective of whether the pertaining to the age and the sex, all the patients comes under high risk category. Once the nodal disease is present in a given case, if there is no nodal disease, the disease limited only to thyroid, then we have to categorize the patient into low risk, high risk, depending on the size of the nodule, on histopathology, well-differentiated category, the age of the patient, and sex of the patient. If nodal disease, everything is forgotten and it comes under high risk, and this is a protocol we need to follow, sir.
Yes.
I think Ramesh will agree with my...
Just a nodal involvement will make it a high risk.
Yes, sir. Nodal involvement is always high risk category.
High risk category.
So in all these patients, you'll do a whole body scanning to look for any residual disease. If possible, you try to re-resect it or put the patient on ablative dose of radioactivity.
So whenever possible,
we do continue suppressive dose of
if the nucleate person says the total ablative dose required in that particular case to ablate exceeds the toxic dose, then the resurgery comes into action. If he says if he can ablate the disease, either local, regional, or a distant by ablative dose, definitely the treatment of choice will be ablative I-131.
Now the next question to Dr. Kannan sir.
Yes, sir.
Tell me something about the hypocalcemia following total thyroidectomy, sir.
Hypocalcemia, sir. Yes, sir. After total thyroidectomy. That's why I told initially you need to have a serum calcium level. Then the clinical presentation and the biochemical presentation. The circumoral numbness and maybe the initial feature of a hypocalcemia. Then we need to know the serum calcium level. Then give a calcium supplementation, intravenous supplementation, followed by oral cap.
Yes, sir. This question to Dr. Ramesh. The patient comes for review after 6 months, TGSA 250 nanograms per ml, and on whole body scanning, there is a solitary secondary in the lumbar vertebra. How will you manage those patients, bony secondaries?
And the lumbar vertebra, if it is not involving the pedicle or just the lateral process, if you can always go ahead with the surgery, sir. Because whenever there is a possibility of surgical resection, we'll always go for a surgery. Here, just the lumbar vertebrae, the part of the involved, which part of the vertebrae involved is most important in deciding about the surgery. If it is the spinous process, lateral process, you can always go for a surgery, surgical corrections, and followed by radioactive iodine ablations, etc.
This question to Dr. Jailal. What is the treatment plan for a visceral secondary, for example, in liver or lung? What is the treatment of choice?
No, there is, once it is a liver secondary is there, I mean, definitely not like a colorectal malignancy, it's not an operable condition. It is only a palliative management can be there. And in front of us, now the drugs like monoclonal antibodies are coming out, sorafenib is coming out. So these drugs can be tried. But if it is a functioning, where still we are getting the levels of, functioning levels are high, you can still try with the suppressive dose if it is a original cancer was a well-differentiated carcinoma. Otherwise, operative management, it is ideal to start antibody, chemotherapy like a sorafenib can be tried. And otherwise, it is only a palliative management can be done. I think anything added, probably Dr. Paul maybe add something more on that issue.
Dr. Paul? Visceral secondaries.
Yeah. So visceral, as you mentioned, bone, we definitely want to resect. Most visceral secondaries are best managed with iodine, or if not responding to iodine, we use tyrosine kinase inhibitors. There's a rare instance when you have isolated visceral, like brain. We had a few patients come back with brain metastasis. If it's solitary and not taking up iodine, then the question becomes, is it metastasis or is it a separate lesion? So we've actually had a meningioma removed like that. Or you can excise it to first of all confirm that it's not the same lesion or it's the same lesion, and then you may have to give whole brain RT for brain. For liver, not in papillary as far as I remember. Medullary cancer, we have done liver secondary excision. Lung, usually surgery is not indicated. Yeah, that's all I can think of.
Sir, Madhu sir.
Sir, please unmute yourself, sir.
Sorry. Dr. Gurusantappa, what is the treatment plan for a follicular carcinoma, sir?
Yeah, if it is a pre-op approved follicular CA, whether it is a unilobar disease or a bilobar disease, the treatment option would be total thyroidectomy. It is very less likely to have a nodal involvement in the neck if it is the histology is follicular CA. One speciality with follicular CA, if it presents with pulmonary deposits, maybe single or multiple, in spite of having deposits, it's better to have a surgery on the primary, doing a nice total thyroidectomy, because there are chances that there is an entity called a spontaneous regression of the tumor. So by doing primary surgery on the primary tumor in the thyroid in the form of total thyroidectomy, there are chances that these secondaries may get resolved themselves after some time with a suppressive dose of thyroxine treatment. So the treatment option for follicular CA is a total thyroidectomy.
So I could see Dr. Pandeyaraj, RAP.
Hello, sir.
Yes.
How are you, sir?
Dr. Pandeyaraj, sir. Fine,
Thank you,
sir.
Mother. Thank you.
Yes, sir. What's the treatment plan for an anaplastic carcinoma, sir? Dr. RAP.
The anaplastic carcinoma, anaplastic. Actually, we were doing hysterectomy in the beginning. Now, total block dissection, including the trachea. Hello?
So if it is operable, you will go for total thyroidectomy.
Yes, sir.
And if it is hard, fixed, patient is struggling for respiration, you will go for tracheostomy.
Yes, sir. Yes, boss.
Yes, sir. So now, yes, sir. Anything you want to add?
Sir, most often this anaplastic carcinomas, like for the postgraduates, if we are asking something like this, we expect them to have an answer like straight away as don't do anything or submit them for radiotherapy, or if the patient comes with a stridor, submit him for doing a tracheostomy, simple tracheostomy. Otherwise, most often, if your diagnosis is going to be anaplastic CA in a thyroid cancer, sometimes these poorly differentiated resectable tumors, so-called papillary CAs or well differentiated cancers, histopathology comes as a surprise as anaplastic carcinoma. Very poorly differentiated, well differentiated malignancy. Otherwise, primarily knowing that it is anaplastic cancer and planning for a surgery, not very often we come across such a situation.
There is now one role for neoadjuvant chemoradiation has been tried in these situations. And then you can reassess for operability after that. So we have done a couple of cases like that.
Okay.
And again, this question to Dr. Paul, because he is doing a lot of research on this. What is our treatment plan for medullary carcinoma thyroid?
For medullary, again, it's primarily you have to first see whether it's sporadic or familial. So if it's a familial type, of course, you have to make sure there is no pheochromocytoma before you operate. And once that is a sporadic type, we will, the only difference is the nodal disease is more aggressive. So the surgical treatment for nodal disease will be more aggressive than a well-differentiated thyroid cancer. And we use calcitonin and CA as markers primarily upfront to see what is the level of that can actually predict the involvement. So there is the calcitonin based involvement of nodes also has been published, saying that if it's up to 150, then you know that even the contralateral lymph node can be involved. If it's more than 500, then there's likely to be metastatic disease. So it correlates with the level well. CA correlates with aggressiveness. So as it de-differentiates, the thyroglobulin comes down and the CEA goes up. So although not many people do it up front, it's a good marker to do even in the beginning, because you'll know whether you're dealing with a aggressive disease or not. And for follow-up also, you can see the level. Both, you must follow up both calcitonin and CA. So generally, surgery is more aggressive for medullary cancer. Yeah.
Dr. Paul, how would you decide about the nodal dissection in medullary carcinoma? Now we are now the latest guideline says depends on the calcitonin level.
Calcitonin level,
Whether
yes.
to do a ipsilateral or bilateral dissections.
Yeah.
Previously, we used to do that depends on the side of the nodule.
Yeah.
Now, what criteria
You have a
taking
lower threshold for doing a contralateral. So even if you can't pick up on imaging, sometimes we do a prophylactic. Like so, prophylactic nodal surgery is more indicated in medullary. So the cutoffs are right from 20 level of calcitonin. 20 means ipsilateral central neck, 30 is contralateral central neck, 50 is ipsilateral lateral neck, and 150 will be contralateral lateral neck. So that is an approximate cutoff. So you can decide based on that. If your imaging has not detected, you should still go and do the opposite contralateral lateral. That is usually the one that is questionable whether you should do. So you have a low threshold for doing prophylactic contralateral lateral for a medullary cancer. And also it's good to do a CT because mediastinal involvement also will be more than in a differentiated.
Yes.
So upper mediastinal nodes can be removed from the neck. So if you have a CT neck and thorax, you can see the levels of involvement and decide your surgical strategy accordingly.
So you said,
sir, just for clarification, Paul, sir.
Yes.
For a clarification, if clinically it is N0 and imaging has not shown any nodes, and if you are talking about prophylactic neck dissection in a medullary, is it understood that you are talking about the central neck? It is not the lateral neck in medullary
no,
CA?
even lateral. We both. Now, in medullary CA, for any proven medullary cancer, the central is always dissected. That is given.
So that is called prophylactic central neck dissection.
Yes.
In
Yes.
medullary CA.
Yeah. So
because
based on the
imaging.
Yeah. Imaging is not good at picking up
demonstrated.
central disease anyway. Yeah, clinical imaging you won't pick up. And because it aggressively involves the nodes more than differentiated thyroid follicular cancer, follicular origin cancer like papillary, you do a central compartment dissection prophylactically for any medullary cancer. That is there. Now, based on the calcitonin level, you can do prophylactic lateral also.
Okay.
That's what we're talking about.
Having discussed prophylactic neck dissection, what is your comment on prophylactic thyroidectomy in medullary cancer?
Yeah, so that again, now what we recommend is genetic screening for all cases. So it may be apparently sporadic. That means that may be the index case in the family who's presenting to you. Parents and grandparents do not have disease, uncles, aunts, you can't find anything, but he may be the index presentation. So it's always recommended to do the red testing on any medullary, even if it looks sporadic by history. So based on that, then we check the family. Supposing it turns out to be red positive, and the most common is what we call the 634 mutation, which has a high risk of developing disease early. So then classically you will check siblings and children. So supposing, I'll tell you an example, one lady who had positive, and then she had two daughters. The daughters, one was positive, one was negative. So the negative one, we can say you're fine, don't worry. The positive one, we did calcitonin screening. The ultrasound was negative. She came when she was 9 years. By 11 years, already the calcitonin had gone up, and we offered prophylactic. They took some time to decide. Finally, we removed the thyroid, and in that already we could see C-cell hyperplasia and micro MTC had already developed. So then we kept following up. By 17 years, she developed bilateral pheochromocytoma, and we took those out prophylactically. So that is the advantage of doing genetic screening. You can, whereas the mother who hadn't had the opportunity to screen, unfortunately, developed metastatic medullary cancer and a very aggressive course of the disease.
And the last question, interesting question to Dr. Guru Santappa. The malignant nodule in the thyroid is cold, whereas the same secondary deposit in a bone is hot. How it occurs, sir? What is the rationale, sir? Dr. Gurusantapa?
Yeah, in the nucleate scan, it is I'll put in the other way around. There are likely chances that the cold nodule in a thyroid is likely to be malignant. It is not the other way around. Why means the area where there is a tumor in the thyroid node doesn't take up the nucleate. I-123 or a technetium, it will not take up. So that will be depicted as the cold, which is not taking up the nucleate.
So normally,
Yeah, can I actually had the chance to discuss this with my nuclear colleague. It's
for
an
thyroid, for
interesting.
routine thyroid scans, we use the plain technetium. So it will not be taken up by the malignant nodules. Whereas for the bone screening part, they use these technetium phosphate scans. So these phosphate, because of the osteoblastic activity in the bone metastasis, they tend to give up a hot spot. I think that is the reason.
Not for technetium, for iodine when it is hot and cold.
It's for iodine. Yeah. No, the answer to that is actually it's relative. So a tumor in the thyroid has relatively less uptake of iodine than normal thyroid. So it will appear cold relative to normal thyroid. But when it goes to a bone metastasis, bone doesn't take up at all. So it will look like it's hot. I think that is that the answer? That according to my nuclear colleague.
Maybe the nucleus and mitochondria also has a role now, sir, because the technetium will be looks hot in a cold, malignant nodule.
Nowadays we are doing only the technetium scans.
That is because of mitochondria it will be taken up. But instead the nucleus may not be taking up this. Not a full answer is not known. I mean, even Madhu sir, we also want to know that answer.
Which one, sir? Hot and cold, difference, sir.
Yes. Why it is malignant nodule is cold in iodine and bone is secondary.
The interpretation is done based on the uptake of adjoining tissue. In malignant nodule, it will be cold, whereas the normal thyroid will be taking up. Whereas in bone, it will be taking up the radioactive iodine, but not the rest of the bone. That is why the difference, sir. And almost we are coming to the conclusion, sir. We have given a clinical scenario, and mostly we discussed the papillary carcinoma thyroid mainly. Of course, few slides we discussed the other type of cancers from thyroid. The papillary carcinoma thyroid is the most common thyroid cancer. It is a slow-growing tumor with prognosis. The specific nuclear features we discussed, and total thyroidectomy is the treatment of choice for all preoperatively diagnosed thyroid cancers. And the neck nodes are dealt either with central neck dissection or lateral neck dissection. And we discussed the post-operative management of thyroid cancer. With this, I thank all the faculty members for having participated and contributed a lot to the panel discussion. And with this, I hand over the mic to Dr. Kanagavel. And again, my sincere thanks to the Chennai City Branch ASI. Dr. Kanagavel?
Yes, sir. Maradhu sir, thank you. And we have few surprise guests also. Professor Siddesh sir from Mysuru is with us today. Good evening, Siddesh sir. I think you joined us midway. Thank you.
Invite me. This was an interesting. We had a EC state chapter because we are conducting a mid-con.
Yes,
we are discussing about the modalities on the web platform. I would be sending out the request. You all can join in, and it will be somewhere in the October. I will send the program also. So people who are interested can join in. That discussion was going on, and later that I could join. Thanks for the invite, Kanagavelu, Chandru.
Sir, welcome, sir. Very happy to see you here. Welcome.
Nice. All profiles are changed in COVID times, Chandru. You're looking smarter.
Thank you.
Thank you.
Thank you.
I learned a lot. But anyway, that was discussion on medullary carcinoma. I really enjoyed. Thank you.
Thank you, sir. Now I request Vivek sir to give the final closing comments as Director of Surgical Studies before I ask Secretary sir to give the vote of thanks. Vivek sir, you are as a Director of
Can
Surgical
I say
Studies.
what do you think? This setup, this Madhupandian sir was organizing, moderating it. It was really wonderful. I think that is
Yes, sir.
we have a
Sir.
different session.
Excellent job.
This session is really an excellent format.
Sir, we have been working for PGs. Now we want to do for faculty exclusively. So in fact, I requested him, sir, you take the standards up. Now many questions which are normally asked in the exams are also covered up here, because this is a forum where we have surgical endocrinologists, we have surgical oncologists, we have all the senior combination of FLARA faculty. In fact, Mardhu sir took the liberty to get the best of the faculty possible for this event. And in fact, last 2 days, I'm sure he was also committed in multiple things, but he ensured the questions are very orderly formed, and he made sure everything is. In fact, I would say he never even asked for slide change. He verbatim had a flow of questions. I had to scramble the slides now and then because he had very clear vision in his mind. So he has framed the questions in that order, and he took everything in the same order on what slides he has shared with me. I personally, as a chairman of Chennai City branch, I thank Mardhu sir for taking this important assignment. And on ASI part, he is the immediate past chairman of the Tamil Nadu ASI chapter, and he has been guiding us with all the activities. He has been at least, he is always friendly with Chennai City branch. Like I think last 5 years, I have disturbed him more than 5 times or 6 times. And whenever time permitting, he will be there even for a short 1 hour or 2 hour also. He used to take flights and come to Chennai City branch program. I think last 3 annual meetings, he has been with us at various capacity. Earlier, sir was secretary and then chairman. Whatever invitation, if we are asking for Chennai City branch, he never says no. And he is also instrumental in restoring normalcy in Chennai City branch. Thank you, Mardhu sir. And I should also put on record the efforts taken by our EC members, Dr. Chandrasekhar, Dr. Vivek sir, Dr. Utrakumar sir, Dr. Kannan sir, the entire EC team, Dr. Rajendran sir, Dr. Iser Vinson. I think few of them had challenges. Professor Balamurugan and Professor Sagai Inbasegar sir had all through internet issues. And we have many surprise visitors joining us for the initial phase. And I thank Guru Shantapa sir. In fact, he was a visitor, then we had to pull him up, and he contributed more to this evening program. Thank you. And I should put on official thanks to Professor Kannan sir, Director, Institute of General Surgery, for joining us promptly and contributing his wisdom. Professor Ramesh sir, HOD, Surgical Oncology, Madurai Medical College, for sharing his wisdom. Professor M.J. Paul sir, Professor and Head of the Department Surgical Endocrinology, Christian Medical College, Vellore. Professor Utrakumar sir, Professor of Surgery from JCS Medical College, Chennai. Professor Balaji Singh sir, Dean and the Head of the Clinical Services and Head of the Department of General Surgery from Sri Ramchandra Institute of Higher Education and Research. And Professor Jayalal sir, Professor of Surgery, Tirunelveli Medical College. And Alex sir also had some internet issues. He was not able to continue to participate. Apparently, sir is in his village, and because of heavy rains, the internet was down. So he tried to join using his phone, but he could not continue. Anyway, we will have Alex sir in one of the future programs, and faculty who missed to share their wisdom, we will definitely ensure to have them in the forthcoming courses. And I also put on record the national faculty, Professor Ajay Khanna, Professor Pankaj Modi, Professor Hitesh Andaria, Professor Rajiv Nandan Sahai, and the entire galaxy. We could see Professor Kannan Raji, the Secretary of the Pondicherry ASI, who for joining us, and many senior faculty who are contributed for today's thyroid symposium. And also warmly welcome Siddesh sir from Karnataka ASI for joining us. So in
Thank you.
fact, if I missed out on someone by not thanking them personally, please accept my apologies. It is out of oversight. not to miss you or not to disrespect you. In fact, Pandi sir just called up, hey, I want to join. So that is the authority my teachers have taken to us. Thank you, Pandi sir, for making time to join. I also warmly this will be available permanently in the ASI Chennai City Branch YouTube channel. Dr. Chandru and the website team, Dr. Iser and Pandi will be getting ready with the Facebook live and YouTube continuously. So we hope to have multiple programs. The EC of the Chennai City Branch deliberated couple of days before regarding various programs. We are planning for weekly academic activities involving across the state as well as the national faculty, various societies. So look forward to have dynamic activities from Chennai City Branch. I would say now this COVID has removed the boundaries. It is no more Chennai City or Tamil Nadu state or India or international. So let us utilize this boundaryless academics. So I'm sure we will be expecting you to contribute, and you also send the message out. And if you feel that Chennai ASI City should do some specific academic program, please reach out to our Dr. Vivekananda Subramanianathan sir. We are always willing to bring in program. In fact, our EC Chandru and Vivek sir has told us we should also have international faculty, which we are working on. So we will shortly have a combined program with RCS and possibly SAGES from USA. So look forward with for more dynamic academic activities from Chennai City Branch. And I also to thank, we had totally 102 participants today's program. We had about 25 to 27 in the YouTube. We have peak concurrence of about 102 on a mean average of about 60 participants in YouTube channel. So I thank all the participants in the YouTube channel also. And we warmly welcome you for future programs, and our communications team will communicate about the future programs also. Now I request Vivek sir to give his closing comments and then vote of thanks by Dr. Uttarakumar. Vivek sir.
Today, excellent and wonderful session. I thanks for ex-dean of Madurai Medical College and HOD of Madurai Medical College. I thanks he is a person to eminent to do everything. I thank for all the eminent faculty and professors. Very useful for the PG students. For most of the examiners also in this session. So our aim, we have to give a good surgical knowledge from eminent persons across the country and from Tamil Nadu, Chennai. So our, already we are conducting a national program also. So everyone so far till now cooperating. So thank you very much, my wholeheartedly, I thank you. Thank you.
Thank you, sir.
Good.
Chandru, you would like to add some
Oh,
remarks?
no, sir. No, sir. Uttarakumar, sir.
Please.
Your voice is very good, Basandro. We hear something.
Sir, he is high definition. High energy, high definition.
High energy.
Uttarakumar, sir, please propose the
Yeah.
vote. And we'll close.
On behalf of Chennai City chapters, heartfelt thanks all the panelists participated in the panel discussion, who are all enlightened as well-differentiated carcinothyroid. Such a deliberation is very useful to all of us, and given more take-home messages which can be applied to our day-to-day practice. So, moderator Professor Madhubandian sir, who conducted the panel discussion in a fantastic way and prepared the questions in an eloquent way, is really indeed. And organizers, I would like to mention here Dr. Kanagal sir, who is the pillar of this program and organized these meetings in a fabulous way within the shortest period span of shortest time. And finally, this once again, thanks to all the participants and the national faculties for rendering their valuable time for watching this program. Thank you, one and all.
Thank you, sir.
Thank you. Thank you, sir.
With the permission of all the faculty, we formally close this program. Any faculty would like to add something to it?